All right, let's talk endocrine meds. We're going to break this all down, whiteboard style, so you can actually see how these drugs work inside the body. This is all about nailing those core mechanisms, the must-know side effects, and the nursing interventions that are definitely going to show up on your exams.
Okay, so here's the game plan for our tour. We're hitting the pituitary, then the thyroid and parathyroid, jumping over to corticosteroids, and wrapping it all up with diabetes meds. Let's dive right in.
First up, the pituitary gland. We're kicking things off with the body's master controller and zeroing in on how it handles one of the most vital things, water balance.
So what's the actual problem we're trying to solve here? Well, with diabetes insipidus, the body is basically missing its antidiuretic hormone, ADH. The best way to picture ADH is like it's the operator of a giant dam for your kidneys. When ADH is gone, there's no one to close the gates. The water just rushes right through. We're talking massive water loss, which leads to some serious dehydration.
Okay, so how do we fix a broken dam? Simple, right? We send in a replacement operator. That's exactly what desmopressin does. It's a synthetic version of ADH. It steps in, mimics the natural hormone, and tells the kidneys, hey, hold on to that water. And just like that, the floodgates start to close and we get that fluid balance back on track.
But, there's a flip side. What happens if our new dam operator is a little too good at their job? What if they close the dam too tightly? Well, if the dose is too high, the kidneys hold on to way too much water. And that leads to a super dangerous condition called water intoxication. The body's electrolytes get all diluted, and that, right there, is the #1 critical side effect you have to be watching for.
And this is where you come in. Your job is to be the lookout on the dam, to make sure we don't get that water intoxication. You're on the front lines. That means you're doing daily weights. Any sudden jump is a huge red flag for fluid retention. You're tracking every drop in and every drop out. You're monitoring blood pressure, and you're keeping your eyes peeled for those sneaky early signs, like a patient getting drowsy or complaining of a headache.
All right, moving on. Let's talk about the thyroid. I want you to think of this gland as the body's thermostat. It's literally controlling the speed of your entire metabolism.
So with the thyroid, you're really dealing with two opposite problems. It's like a thermostat that's broken in one of two ways. In hypothyroidism, it's stuck on low, and everything is sluggish and slow. Our job? Turn up the heat. On the flip side, with hyperthyroidism, the thermostat is cranked way up to max, and the body's burning out. Our job there is to cool things down.
So, for that slow, sluggish thyroid, we bring in the big guns, levothyroxine. It's a synthetic T4 hormone. You can basically picture it as pouring gasoline on a slow-burning fire. It provides that missing fuel to really get the body's metabolic engine revving again.
Now, this is absolutely crucial. If we add too much fuel to that fire, if we give too much levothyroxine, we can completely overshoot the mark. We can accidentally flip a patient from hypothyroidism straight into hyperthyroidism. A racing heart, chest pain, sweating like crazy, those are all telltale signs of toxicity. It means we've cranked that thermostat way, way too high.
Okay, let's tackle the opposite problem, that overactive furnace-like thyroid. To cool it down, we use drugs like methimazole. What it does is it gets in there and blocks the factory from producing any new thyroid hormone. It slams on the brakes. But, and this is a big but, there's a major risk. Agranulocytosis. That's a scary drop in white blood cells. So if your patient suddenly spikes a fever or gets a sore throat, that's a medical emergency. It needs to be reported like yesterday.
Next up, we've got the parathyroid glands. Don't let their size fool you. These little guys have a massive job. They are the undisputed kings of calcium regulation in the body.
Let's really visualize this. In hyperparathyroidism, you can think of the bones as a bank vault for calcium, and the parathyroid is telling the vault to just keep throwing calcium out into the bloodstream. This makes the blood rich in calcium, but leaves the bones weak and empty. So what do? We bring in drugs like alendronate. These are like security guards for the vault. They go after the osteoclasts. Those are the little cells that are actually carrying the calcium out of the bone, and they stop them in their tracks. This stops the calcium leak and helps the body put that calcium back where it belongs, in the bones.
Okay, exam alert. These instructions for alendronate are pure gold for test questions. This drug can be really harsh on the esophagus. I mean, really harsh. That's why these rules are non-negotiable. It has to be taken with a full glass of water, first thing in the morning, and the patient absolutely cannot lie down for at least 30 minutes after. You've got to make sure that pill gets all the way down to the stomach without getting stuck.
All right, let's shift gears to one of the most powerful drug classes you'll ever encounter, corticosteroids. The easiest way to think about these is as the body's own SWAT team. When there's a major crisis, like massive inflammation, these guys are called in. So these glucocorticoids, like prednisone, are incredibly powerful anti-inflammatories. They're the ones we use for huge flare-ups, like a severe asthma attack or a crazy allergic reaction. They work by basically telling the entire immune system to stand down. But as you can imagine, keeping the SWAT team deployed 24/7, well, that's going to cause some major problems, especially with long-term use.
And this slide right here, this is the classic textbook picture of what happens when that SWAT team stays on duty for too long. The body starts moving fat around in some really weird ways. It goes from the arms and legs and gets deposited in the face, that's the classic moon face, the upper back creating a buffalo hump, and around the middle. On top of that, blood sugar goes up, and the immune system is so suppressed that the person is at a huge risk for infection. These visual cues are total gimmies on an exam.
So, why do we hear never stop steroids abruptly over and over again? Here's the physiology. When a patient is taking steroids for a long time, their own adrenal glands get lazy. They just stop making the body's natural steroid, cortisol. If you suddenly pull the plug on the medication, the body is left with absolutely nothing. And that can throw them into a life-threatening adrenal crisis. That's why tapering off is not a suggestion, it's a rule.
And that brings us to our final section, a true cornerstone of endocrinology, managing blood sugar with diabetes medications.
Think of this table as your go-to cheat sheet for oral diabetes meds. It's awesome because it shows we have so many different tools in our toolbox to fight high blood sugar. You've got metformin, which tells the liver to chill out on producing glucose. You've got sulfonylureas, which are like a drill sergeant for the pancreas, yelling, "Make more insulin." Then you have something totally different like the SGLT2 inhibitors, which open up a new exit for sugar through the kidneys. Knowing how each of these works in a different place is absolutely key.
Okay, everybody, listen up. If you memorize only one thing about metformin for your boards, let it be this. Metformin and IV contrast dye are mortal enemies. They do not play well together. The combo can absolutely wreck the kidneys and trigger a nasty condition called lactic acidosis. So holding that metformin before and after a scan with contrast isn't just a good idea, it's a critical, life-saving intervention.
Now, let's get practical for a second and talk about insulin injections. Location, location, location. It really matters. The abdomen is like the express lane. It has the fastest absorption. To make sure the insulin works predictably and to avoid that lumpy, damaged tissue called lipodystrophy, you have to teach patients to rotate their sites. The key is to rotate systematically within one area, like using different spots on the abdomen for a week before you pack up and move to a new neighborhood, like the thigh.
And here it is, the classic nursing school question you're guaranteed to see. How do you mix insulin? Just remember the mnemonic RN. You drop regular first, then NPH, clear before cloudy. But why? It's simple, really. You don't want any of the long-acting, cloudy NPH getting into your vial of fast-acting, clear, regular. It's all about keeping the fast stuff fast and uncontaminated.
So that wraps up our tour through the endocrine system. We've seen just how powerful these drugs are, literally recalibrating the body's most delicate and intricate balances. Which really brings us to this final question. When you think about everything we've covered, from water intoxication to adrenal crisis, which nursing intervention do you now see as the single most critical safety net for our patients? It really makes you think about how vital our role truly is.